So this conference is, I think we had organized ICTD in 2019 January last year, and a fallout of that is we want to take these discussions further, go deeper into some of the issues of ICT using healthcare. There are multiple initiatives which are happening in India, and we should learn from each other. That was the initial thought in the last ICTD conference, and luckily we had some money left. So this conference is a offshoot of that money and the thought which was in that conference. So what we did is we invited practitioners who have been in thick of doing things, say implementing telemedicine, writing policy, or say AI in healthcare, and we wanted to bring all of the stakeholders together, diverse stakeholders, so that we can learn. But many of you are first timers in Ahmedabad. We have with us Professor Bandyopadhyay. He is our Dean Faculty, and he has kindly agreed to inaugurate the session. We will request him to stay here and also learn from us and give his insights on these initiatives. He has worked in ICT in healthcare long back, not ICT in healthcare but ICT in education. But it's okay, it's a development field. The design of the conference was a round table. Why a round table? Because there was no formal presentation mode that somebody will speak because he or she has done something and she wants to showcase. ऐसा कुछ नहीं था. So the purpose was everybody is equal and everybody can contribute and anybody will learn. So that is what the purpose was, round table, and that's why the circle design of this conference. It is not efficient space wise, but it is effective communication wise. So that was the purpose. I would request Professor Bandyopadhyay to say a few words, inaugurate. We will have tea first and then we will start, like all Indian conferences.
Thank you, Rajesh. So, I know very little about the applications of ICT. As a common man, what I learned that I can tell you, but I have some ideas that I would like to share with you. So, ICT, particularly AI, is used a lot now in US and other places. For example, they are using artificial intelligence for an efficient diagnosis or efficient and accurate diagnosis. They are using AI for discovering new molecules. That is so that the pharmaceutical companies they can reduce the cost of discovering drugs. It's a huge amount, possibly all of you know. They are using chatbots for helping patients to share their symptoms and whatever, and accordingly they are also advising through chatbots, and even the physicians are taking help of chatbots. And also finally the robot assisted surgery. That's a new thing that's happening in US. But in India, I don't know. My only concern is I remember a story when I was in Apollo, not Apollo, this place run by missionaries near Chennai, Vellore. I was in Vellore with my mother long ago, 20 years ago. He had a stroke, she had a stroke. So I was there for a month with her and one of the students, she was at that time studying MBBS in Vellore, and I asked her what is unique about the education here. So she told me something very interesting that actually struck me at that time, and I will never forget that. She said that suppose I am visiting patient along with my supervisor, and the supervisor asked me to write the prescription. So I wrote the prescription, and he looked at it or she looked at it and said, your prescription is okay, but it's not right. She said, why? Then her supervisors told her that there is a medicine which is cheaper than this. Why are you prescribing a medicine which is so expensive? Okay, so that struck to me, and also I still think that a country like India, whatever we are doing using ICT, whatever we are doing to enhance efficiency, accuracy, we always need to think about the cost. That is, most of our people are poor, so if we can use ICT or AI to enhance the efficiency and accuracy, but those kind of treatments may not be accessible to the poor, and that won't help India. Okay, so I think that is one thing. I think that ICT, how ICT can help in reaching out the poor patients and reducing the cost of treatment. Even the insurance is another, where insurance, actually health insurance is every day is increasing, the premium is increasing. How ICT could help in reducing that. So to me, cost as well as quality, of course quality is there, but cost is most important for a country like us. And I think that you people are very distinguished professionals in this particular area, so you would be able to deliberate and discuss and come up with some ideas. As Rajesh was saying, that it's a platform where we deliberate, we learn from each other. I hope this 1.5 days discussion will bring out a lot of new ideas, and possibly we can pursue that in future. Thank you very much.
So now, because all of us are from diverse, some of them know each other, but many of us are meeting each other for the first time. What we'll do is we'll have a brief round of introduction, starting from ma'am, and you can tell about your initiative, startups, or experience in ICT in healthcare, and what do you seek from this conference?
Thank you, Dr. Rajesh, for this wonderful opportunity. Myself, I'm Rupal Mehta from Pune Marvel Software Solutions Private Limited, and we are working on neuroimaging solutions treating epilepsy patients in India. We have a tremendous experience in developing some of the radiology information management PAC systems in US, and now leveraging that experience and expertise to Indian market is what we are looking forward to. And all of you here can help contribute in developing our solutions. It's a medical imaging and informatics solution where it will bring a lot of doctors and clinical partners on a single platform for treatment of patients with neurological disorders.
Hi, good morning. This is Ashish here, and I read an interesting piece sometime back which said that we are number 5. India is number 5 in terms of publications in the world. So obviously, US is number 1, China number 2, UK and Germany, and then stands India. The point here is that Indian basic science publications is growing at about 14%, whereas the world above us is growing at about 4%. So very soon we are going to jump to number 3. That said, if you look at the commercialization, there are huge gaps. So what happens in research, what happens in academic world, and what happens in the industry, there's a lot of difference. So I represent a company called BioQuest, and we are playing our own small contribution there. We are trying to bridge gaps here. And so we work with academic institutes and universities like Harvard, Duke, University of Chicago, this side, University of Western Australia, even a lot of Indian hospitals and universities. So we're bringing them together and closing these gaps with the industry. So I represent this company, BioQuest. Thank you.
Good morning, everyone. My name is Meenu Singh, and I'm professor of pediatrics at PGI, which is Postgraduate Institute of Medical Education and Research in Chandigarh. I'm actually a pediatric pulmonologist, but about 20 years ago, I have also started looking after the telemedicine initiative in PGI, and currently I'm heading that department, which has recently been started. And we are looking forward to developing a National Institute of Telemedicine, for which we have received the approval of the governing body. Our initiatives have been initially in the field what we called as telemedicine. Now it's evolving into e-health and m-health and digital health. And now that we have this National Digital Health initiative which has come up, and there's a mission which is starting on that, we are implementing telemedicine at health and wellness centers, which are part of the Ayushman Bharat Yojana. So that is the government part of it in which we are working, but we have several other initiatives which we have started, and some of them are by CSR from companies like Hewlett and Packard, in which we are developing certain models of healthcare delivery in the periphery of the country, where something like reaching the unreached. And we have also forayed into diagnostics through remote diagnosis, and we have partnered with Bhabha Atomic Research Center in their tele-ECG initiative, and we had this project on telespirometry, which we are still validating. So we have a regional resource center, which is part of a national project called National Medical Colleges Network, which is part of National Knowledge Network, actually. And we are looking after all the northern states for implementing all the policies, and also doing a lot of projects, which I think I will be alluding to from time to time. And our main areas of concern in this field are that we need regulation, we need ethics, we also need policy advice to continue, and we really need to scale up some of the solutions which are already being developed, and go in a very coherent and concerted way that we implement all this for wellness and for welfare of our population. Thank you.
Good morning, and thank you, Dr. Rajesh, for the invitation. I'm Sonal Asthana. I'm a liver transplant surgeon working at Bangalore. I work in both the private and the public sector in the Bangalore Medical College, as well as at Aster Hospitals. So there are a few initiatives that perhaps sort of brought me to this meeting. The first one was regarding cost of care. We have been working on using technology for reducing the cost of care for pediatric transplants, raising money through crowdfunding as well as through 3SR initiatives. And now we can offer pediatric liver transplant for 2.5 lakhs. We've reduced it from 25 to 2.5 lakhs using this initiative over the last 3 years. The second initiative is using a web-based organized developmental training module for organ retrieval training, which we did along with Mohan Foundation and with Oxford University for the last 5 years. And we've trained more than 150 surgeons using a standardized technique. The third was regarding clinical data collection. As you know, India does a lot of transplants, but we don't really have any clinical data. So I have convened the Indian Liver Transplant Registry as an offshoot of the Liver Transplant Society of India. This was launched on August 15th last year, and it currently captures 70% of all liver transplant data that's being generated in India. So these are the three initiatives that I think would be of interest to this group. Thank you.
Good morning, everyone. I'm Gaur Sundar. I'm from CDAC. I have two roles which could be of interest here. One of them is that I head the medical informatics technology R&D group at CDAC Pune, where we develop tech tools. I've been there for about almost 19 years. I'm completing now there. And over the years, we have what Dr. Singh was referring to, the telemedicine. The original tech of it was developed along with my team way back in 1999, 2001. And since then, in the public health, we have deployed telemedicine across the country in several states. My own team's work is now moving towards PSU-based hospitals. So we are going there. Orissa, all districts, hospital, etc., they run telemedicine over our platform. About 13 ICUs are connected over the same platform, etc. Other than that, my team also develops technology for health exchange and things like that. One of the major work from technology angle is indigenization of products. Very recently, you may be aware that India is trying to indigenize the cancer radiation machines, the brachytherapy machine, the teleradiology machines, and the LINAC machines. We are developing the treatment planning system. It is one of the costliest piece of technology when it comes to cancer treatment in terms of software. So we have recently developed a fully indigenous solution for brachytherapy, which is now undergoing intensive testing at Tata Memorial Center. Other than that, the other hat that I wear is I head the National Resource Center for EHR Standards, which is a resource center created by Ministry of Health. The primary work is to provide support for implementation of health standards or IT standards into IT solutions. We do it for free across the country. So we have held more than 1,000 seminars across the country so far. We are advising state governments, we are advising the central government. I work with agencies like BIS, STQC, NABH, and so on in order to bring IT standardization into the system. I was also part of the severally standardization effort of the government. I was part of the telemedicine standard protocol which was developed. I was co-author of the EHR standard V2, which came out in 2016, and recently I was also member on the National Digital Health Blueprint Committee of the Niti Aayog and Ministry of Health and Ministry of IT. So now my major work is, about 50% of my work is basically pushing standardization into health IT systems. And as we go along, we'll discuss more about it. Thank you.
Good morning, everyone. I'm Rakesh Gupta. I'm Project Director of Chief Minister's Good Governance Associate Program in Government of Haryana. Along with that, I'm Nodal Officer for Beti Bachao Beti Padhao Haryana, and plus I'm State Project Director of a project called Samagra Shiksha, that is in School Education Department. So I'm working in the IAS for the last 23 years. So 2008, I took a sabbatical, went to Johns Hopkins University, did my PhD in health systems. Thereafter, worked in health department in Haryana as Mission Director of National Mission Haryana. Therein, we experimented with lots of ICT tools and techniques to improve the health outcomes. Primarily, we were able to make a major dent in IMR, infant mortality ratio, MMR, and other related indicators. So ICT is a very potent tool. I'm sure most of the people here are clinicians, but I am bringing public health perspective to this conference. My belief is that based on my experiences in multiple fields, including public health, ICT can really deliver if done well. The only thing is that we all have to work as a team and then create data sources, because the problem within the government system is that we don't have reliable data systems which can be reviewed, monitored to deliver the outcomes. Apart from health systems, we can claim that we have been using ICT in multiple ways. For example, we say that we eradicated cheating from school board examination. That was way back in 2003-05. There also we used ICT in a big way, and we were able to do away with cheating to a large extent in Haryana board examinations. And recently we have been working in the field of school education. Here also ICT systems have been built in, and we are able to quickly give the best of learning level outcomes in Haryana. In addition, we have been involved in public service delivery through e-governance, in which we are working on 500 plus schemes and services, primarily G2C, wherein we are using ICT in a big way so that the citizens, they get best of services. Thank you so much.
Good morning, everybody. I am Mayank Kumar, a faculty member in the School of Management of IIT Jodhpur. I do my research in the area of EMR implementation across private and public hospitals, looking at the challenge of designing the applications use and the scalability school. Also the patient, how we can use health IT for patient empowerment. So I'm here to learn from the experiences shared by you, on the implementation and its use in the healthcare settings. Thank you.
Hi, my name is Vijay Pereira and I represent Khalifa University in Abu Dhabi. I am the elected General Secretary of the Indian Academy of Management and the Vice President of the Academy of International Business Middle East and North Africa. My interest has been my ongoing work with Professor Rajesh Chandwani on several aspects, one of which includes the role of ICT and knowledge management in healthcare globally. We are in the process of setting up a business school and a center of sustainability in the Middle East in Abu Dhabi. We have several top multinationals and countries on board. One of the key areas of the 10 areas we are looking at to develop is sustainable global health. And based on that, I think going forward, this conference is going to be sort of kickstart several new initiatives. And I will surely be in touch with the group around the table to be our partners in this process. Thank you.
Good morning, everyone. My name is Glenn Mushert. I'm professor of sociology at Khalifa University, also in Abu Dhabi. And I am a sociologist based in the business school. My expertise is in the area of digital divide, particularly with regards to digital skills and the ability of users to effectively use digital technologies. I'm here to listen and to learn from those who are on the ground in the ICT and healthcare industry. And thank you for having me today.
Yeah, good morning, everyone. At the outset, I'd like to thank Dr. Rajesh for inviting me here. So basically, I'm a practicing physician and diabetologist with the Apollo Sugar Group, and I'm based in Bangalore. So my keen interests are basically diabetes and metabolic diseases. As of now, we have something called the sugar application, through which we do remote monitoring for self-monitoring of blood sugars and also for titration of insulin for many of our patients. And we also have something called the health coach, which is actually overseen by our dietitians and diabetes educators. And through that as well, we help disseminate information and educate patients on complications related to diabetes. But also what we are planning in the future is something called the ICAT program. It's not particularly related to Apollo per se. This is something called in-clinic assisted telemedicine, wherein doctors practicing in Tier 2, Tier 3 smaller towns, mainly my students who have done this fellowship in diabetes program, we want to partner with them and probably help in better diagnosis and management of patients in smaller towns. And we're working on a model on that, which is feasible and does not have any regulatory challenges as well, because it's more of the physical examination, everything is done at the local level, and we are more of an interface to give expert advice on better diagnostics management. So this is something that we are working on. Thank you.
Hi, good morning, everyone. I'm Rajesh Dembla. I wear several hats at the moment. I am an entrepreneur and an angel investor in over 30 startups in India and some outside of India as well. Prior to this, I was part of the team that built Just Dial in India, almost from the start of it till the time we listed the company on the stock exchange, and then I exited out of Just Dial so that I could actively participate in the startup ecosystem. So some of the startups which are basically relevant to this group is companies like where I'm now part of is Dunzo, I Do Delhi, Rapidor. These are all companies that are basically building technology to support any initiative with telemedicine in terms of logistics, in terms of AI-based chatbots. So I see a lot of effort in the startup ecosystem today, and Sir was speaking about AI-based chatbots. I have seen some of these chatbots which have capability to address issues in Tier 2 and Tier 3 cities, regional languages. Pretty good, not right up there, but pretty good. So I'm here basically to understand a little more about Dr. Balaji's effort with telemedicine, and if there is some opportunity for us to do something in that field. Looking forward to that.
Hello, good morning to all of you. My name is Ajish Rai. I've joined IIM as a faculty in Public Systems Group. I'm grateful to Professor Rajesh for inviting me to attend this conference. For me, this is a learning exercise. Thank you so much.
Good morning. I'm Bhudev Chakraborty. I was mainly with the National Institute for Smart Government for 10 years, and starting from 2006, we started working on use of ICT in government and the PSU health sector. So we have actually started that health MMP, the first in 2007, informally, and finally it became formal around 2012. And also got involved in various projects, e-health and health ICT in health projects in various states and in the central government. Even that Haryana, your health project also actually it was designed by us, and we were the first people who started the complete conceptualization and architecture of that project. And so that was up to 2015 I was there. So now I am actually working as a freelance consultant for use of ICT and management of data. So that is one of my role, and we call it design for data, so which is not there in India at present. So that is one area I'm working, and positively involved in various groups, and also working with some other people in this area to make it better. Other than that, I also started a company called Sense Health Technologies with a Professor Amit Acharya in IIT Hyderabad, and we are incubating there. We are lucky that some fund is also provided by IIT Hyderabad for this. So there we are mainly working on use of the sensing parameters to convert some of the informations which we are getting through the sensors to to a knowledgeable format. Like for example, if we have a 3-lead ECG data, we can convert it to a standard 12-lead graphs, whatever is given by any 12-lead ECG machines. So we have already published papers in Nature, in the Journal of Electrocardiology. So this thing has got a huge approval from various places. So now we are planning, because we have already developed the software portions, we have started also developing a small device so that we can give it as a solution that the complete ECG graph from the 3-lead, or now we are even working on reducing it to 2-lead. Somebody was asking me in the morning, is it possible from single lead? I think might be possible, but we have to work on it more. So, but we are mainly R&D. We are not planning for any commercialization at this point of time, but we are positively ready to work with any company who wants to take it through the commercialization process, because my partner is a professor and I'm also doing my freelance consulting. So it is not a good idea of going into the business side. So other than that, also we are working for helping some of the governments. I'm working personally that like government of Bhutan. So for their complete the design of their healthcare systems, we have done. I have created the RFP for them, and I was also involved in managing the whole setup there, and also some work we have done for government of Nepal and government of Bangladesh.
Hi, morning. Thank you, Professor Rajesh, for inviting me and accepting my suggestions. I see a lot of friends with whom I've been working for a long time. You have also brought in here. Many new faces are there. So just to give a background, I'm an intensivist. I'm an acute care physician, trained emergency physician. I worked in the Ministry of Health in Abu Dhabi for 9 years and taught in the Faculty of Medicine there. And then I made a switch to health informatics in 2003. So I trained in Swansea University in UK. I was there for 2 years, worked in the national program for IT in the NHS. I was the assistant head of modernization for one district there, and then joined GE Healthcare in Bangalore. So I was the clinical director for 10 years for GE Healthcare, heading the South Asia business. And so in GE, there is a very interesting concept of in India for the world. And then it becomes, in India for India, and then in India for the world. So those are programs like this, what we are doing, where, all the expertise of the company, GE is a big company, a multinational company, is brought together, and we pick problems which are there, unique to each country. And like India has got its own unique problems. So we try to address, some of them or most of them, and we did a very good job. So that gave us the confidence to actually step out of GE. I completed 10 years in 2015 with GE Healthcare. Me, my CEO and my CTO, from the company we came out, we set up a company called Cohere Med in Bangalore. We are a digital health analytics company, and we are registered in the US. We have our engineering operations in Bangalore. We work very closely with Duke University, so I was happy to hear there's one more person who works with Duke, Mayo Clinic, and MIT Harvard. So these are, being an acute care physician, our work revolves the acute care space. So acute care is emergency medicine, intensive care units, and operation theaters. These three together is called acute care. And there is a whole lot of things that needs to be done in these three areas. So very simply, if you manage the patient well on the field, when there is an accident, the number of people who need to come into the hospital is much lesser. And if you manage the patient well in the emergency, the number of guys who go into the hospital as inpatients can be reduced. And if you manage them well in the ward, the number who go into the ICU can get reduced. So what you see is a cascading effect. So if you look at it the other way, it's not happening. Most of the patients I receive in the emergency die on the field of simple things. Bleeding, neck, malalignment. Like, you are not supposed to shift a patient who has a neck injury, but they will turn him and he will die on the field itself. So these are all very basic things that we can sort out. And somewhere when I was in Abu Dhabi, I got to work on some of these emerging technologies in 1997, 98, those times. That piqued my interest in health informatics. And we automated Al Ain Hospital, which is a teaching hospital in Abu Dhabi. Today, the work we did has been replaced by Cerner Millennium. So Abu Dhabi, UAE for that matter, is a great healthcare IT site. The whole country is on Cerner. And Dubai is on Epic. And these are like the two biggest healthcare IT products that we can have. So this is my work. Apart from this, I do a lot of voluntary work because GE encouraged that, and by nature I like, volunteering and working. So that's where we got involved with the iHind project, as it was called during the Congress government days, which was Health Information Network for India. So iHind, IHIND. And that work continued. Today it is called as Ayushman Bharat. So essentially the same work, the same principle. We looked at India as 600 districts. We conceived a health information network for India. It's all volunteers. So I'm very proud to say that the team of volunteers includes Bhudev, Gaur Sundar, Professor Sunil Shroff, so many of them who are here. And it's just the love for the country that brought us together. And we have done it. Then it ended up with meeting Sujata Rao, who was the health secretary at that time. And she asked us, what is the next step that you want the government to do for you? So we had to define the standards. So that took a lot of time. But then in 2013, I'm one of the authors of the EMR Interoperability Standards for India document, which is published by the Government of India. It was revised in 2016. So it takes a lot of hard work. It takes a lot of teamwork to bring in, people as diverse as this was what you have done, and I must thank you for that. I mean, this is like the kind of thing that, which should be happening in more numbers, and bring in all the stakeholders from the healthcare system so that there's nobody left out who says, humse nahi pucha, my part is missing, I'm a physiotherapist, I'm a pharmacist, how come you guys missed me, that gap should not be there. But what I would like to leave after 2 days from here is what Gaur Sundar mentioned is a huge task this guy has got on his hands. He alone can never pull it through, right? He needs all the help that we can give him. And that's the way we are very active in Bangalore. So we have multiple forums. I'm part of IIM Bangalore Digital Health Innovation Labs also. And we organize these kind of, events and bring people in and, bring the awareness. Most of the people are not aware about what the government of India does. That is my first learning. And then I tell them, boss, I volunteer, I know what is going on. So the National Digital Health Blueprint is very, very ambitious if you look at it. If you read the document, it's available in public domain. But believing in what we can do, very simple. My mentor, Professor Khalid Moidu in the US, always says, hey Tanga, you're building all these things for the world, but what are you building for India? The answer is nothing. That's where, we have to sit up. And I can tell you, in Bangalore, you have Boeing, you have Airbus, you have Rolls-Royce, you have Mercedes. You name the company, they are there. And if it is software, it is there in Bangalore. But we do nothing for India. So that is where the national health stack, which me and Dr. Sonal Asthana got to talk when we were on the flight, is another initiative. Like the Aadhaar has been built, and that is available for fintech companies to build on. So the national health stack is also being built by Nandan Nilekani and team, and it's soon going to be available as open APIs for many, many people. You know, IIM has got an incubator, and I mentor many of those guys. So I tell them, look at the NHS national health stack, build applications. You know, there's no limit to how many things you can build on them, because this is de-identified data of 1.3 billion people. It can't get better than that, right? So possibilities are endless. I think we are on some exciting times, and IIM Ahmedabad is the best and the top institution for management in the country. And you know, what we talk here is being heard, and we have one IAS officer with us, you know, and the people are, you know, who are in control, who are running the show, like Love Agarwal and these people, they're all listening and they're all trying to learn from, you know, these kind of things. So congratulations, and look forward to interacting with all of you. Thank you.
So, good morning everyone. I'm Dr. Amit. I'm primarily a radiation oncologist and now turned into an entrepreneur. So, I'm co-founder of onco.com. We operate in cancer space. So I was kind of, after 12 years of practice, I always felt that there is a lot of gap in what patients deserve and what patients get. And being into that system, it cannot be changed. So I thought maybe we can use market forces somewhere, do something outside the system and push it to coming into patient centricity. So then I went for management, executive management education from ISB, and then started this company with my co-founder. And we are primarily in the space of helping cancer patients get fill the gaps around information. Because if you note, healthcare is the only sector or transaction in the whole ecosystem where the consumer does not have any power. You have, as a consumer, you go to Amazon or any shop, anything, you have power to evaluate everything. You have power to ask questions. You have power to judge and question them. But in healthcare, you don't have any power as a patient because you don't have any information. You surrender yourself. But that determines your destiny. That should not determine the destiny. So we, at least in oncology space, we are filling this gap of information by guiding patients in lucid language, what they should be getting, what is right for them at least. So so we connect them with right specialists who are experts in that disease. We make them know what is best treatment plan from them as per standard protocols. So we have online tumor board services from Indian experts and US experts. Plus we have treatment expert matching algorithms. So geography, patient's condition, status, affordability, and other things we are incorporating slowly to add to the system so that they can identify right experts for them. We also built a first platform. It's we call it Online Cancer Patient Assistance Pathway, OCPAP, which is very simple algorithm, and this is the first algorithm for the patients, built for only for the patients in the world, for cancer patients, where any patient from across the world can just register and give very basic inputs like the type of cancer they have, the stage of disease. Most of the patients know their stage, the condition of patient, and the treatment they have undergone till now. Based on that, they get detailed guidance on what test they should have done by now, what expert they should be seeing, and what treatment plan or what treatment options are there for them. And we published it and we presented it at ASCO. This algorithm, we won award, or merit award at the ASCO Breakthrough. ASCO is world's largest body of oncologists, American Society of Clinical Oncology. So there we won Breakthrough Innovation Award also for this. And we are also now promoting it, even trying to promote with Ayushman Bharat to ensure the right pre-authorization procedures when they are evaluating. An oncologist need not sit there. They use this OCPAP platform just to put basic inputs and obtain whether the treatment that is being followed or that is being asked for is correct or not. We are also working on some care management or care navigation suites within the patient. We realize that we have a chatbot also, you mentioned. The patients we have realized over time, we also have care manager where human interaction is there telephonically. And we have a care chatbot also. We have realized that patients are more comfortable dealing with the product rather than humans. This was counterintuitive. We thought we want to interact with humans, but this is not the case. Patients or caregiver at least are more interested to interact with a chatbot or the product. So we are now working on care management suites where we guide patients, provide them information about their disease, about their side effects, about everything that they need to know through the product itself. So throughout the journey, we are mapping the journey of patients, working on those things. So that's the starting work. It's been 3 years of journey working around that. So, and thank you, Professor Rajesh, for inviting me. It's already a lot of learning has started for me personally. Thank you so much.
Thank you, Rajesh, for having me here again. We were in the same room 6 weeks back, Rajesh, Dr. Rakesh, Sunal, Mini, and some of the fellows. And we were discussing on policies related to organ donation and transplantation. And we had about 120 people in the room. And we had a very interesting session for 2 days. And as a result of which, we brought out a proceedings of almost 80 pages, which is going to be published. I have been involved with organ donation for the last 20 years, 25 years now. I work very closely with my other colleague, Sunal, who's sitting here. And we've tried to improve the ecosystem on organ donation and transplantation in the country. And transplant is an area of cutting-edge medicine and requires a lot of help with technology. I have been associated with this organ donation initiative and technology as well, and I'll tell you a little bit more. In the organ donation, I associated with 3 state registries on organ allocation with state of Tamil Nadu, Kerala, and Rajasthan, where we have an online system for waiting list and when the organ is available, who it is to be given to. And this has been running for last almost 20 years now, with especially the state of Tamil Nadu. We also have an organ pledge registry online, and we have probably the best database on organ pledge in the country. And we have a database of almost 60,000 people who have pledged online for organ donation. The reason I'm here today is that I'm also associated with a technology company called MedIndia. And MedIndia was, I heard that, we are in exciting times. That's what Tanga said. And when I came back from England in 1995, I said the same thing to my brother, who is also an engineer. He's from IIT in Chennai and I'm Ahmedabad. And we said that this is exciting times because internet had just started evolving in India. And we're still in exciting times, so that's wonderful. So with MedIndia, what we've done is we created a platform to network doctors with patients. And over the years, we became the largest website de facto in India, but there was nothing there available. And we, at one time, were getting almost close to 15 million page views a month, which is large traffic for a health site. And then, of course, many other sites have come up over the years. And we are a very content-rich site. We have almost 1 million pages of health content. And the advantage is that it's a validated and trustworthy content because it's validated and it has a HON code. I don't know how many of you know HON code. It's probably one of the sites which is HON code validated in the country. It's called Health4Net. And as I went through this journey in technology, I realized that as there are gaps in India, huge gaps. And from 2000 to 2008, we were doing conferences on medical informatics and telemedicine in India. And we did 4 conferences. We used to do it every 2 years. And that's where I, got to meet Tanga, who is, of course, from the same institute where I was teaching. And I realized that there are a lot of regulatory gaps, there are a lot of legal gaps in this to make digital health actually happen in India. And what was true in 1995 is still true today, unfortunately, after 25 years. I must have made at least 100 trips to Delhi to try and help with some of the regulatory requirements to make this practice happen. And over the years, I got more and more interested towards ethics, the legal issues, the social implications of digital health. And internationally, there's a group called ELSI, which exists in many universities and many institutes. And the reason I'm here today is to see whether we can create an ELSI in India, looking at ethical and legal and social implications of digital health. And I think IIM is well placed for that kind of an initiative, where all the stakeholders from diverse background sit down in the same place and are able to validate stuff which are coming out. There are more than 4,000
500 startups in healthcare today in the country. And they're all looking for directions, and there's no direction. And we need to look at that in a very serious way. Can we just leave it to the government? Government has to do its own bit. We need to change our laws to get things going if we want to bring digital health in the mainstream. Today we are seeing, investments, which are about $500 million coming into healthcare tech every year. You have a regulatory network and then see how it will open. What our Prime Minister is talking about, the $5 trillion economy will only happen, and healthcare tech can be one of the important contributors to the technology economy, because a lot more jobs will come up and things will get more streamlined. So I'm actually here looking at that as an initiative to see whether we can look at that in a serious way and push this. We have Dr. Rakesh Gupta here, and we have people from CDAC, we have Meenu from here. She also has interest in regulatory affairs. So we need to have these people to push the government forward. It hasn't moved in the 25 years I've been around, unfortunately. So this is my interest, and I'm looking forward to interacting with all of you and seeing how we can, help digital health, the so-called health for all, which when I came to India, it went 2000, and then it went 2010 health for all, then 2020, and now we're talking 2030. Will we keep pushing this health for all forever? Or will it ever happen? And how is digital health going to contribute to that health for all? So we need to look at the larger vision and look at this ecosystem and try and infuse some regulatory kind of requirements which are desperately required. Thank you very much.
Good morning, everyone. First of all, I would like to thank Professor Rajesh sir for calling me here. So I'm co-founder of Health Coco Technologies. So it's a 3-year-old startup from Nagpur and Pune. So I'm a hardcore technologist. Did my BTech from NIT Nagpur and passed out from there in around 2012. So I joined Morgan Stanley, that's a fintech company. So for first 3 years of my career, I worked in finance division. After that, after working for 3.5 years at Morgan Stanley, it struck me that now it's time to do something of your own. So I jumped from working for Morgan Stanley and starting my own company. And I started Health Coco with my father. So my father had a bit of experience in finance, as well as he did a startup back in the 90s where he also worked in healthcare. So a lot of ideas were already there when starting this company. So I researched on a lot of things with my team, and we thought that, okay, let's start with, there's a lot of aim for healthcare for doctors. So we built a AI-driven healthcare platform that is a PMS system for doctors. And we connected that with patients as well. So we have an app called Health Coco where patients can search for doctors, as well as doctors can use the patient management system that is driven by AI for having good diagnostics as well. So by working closely with doctors, we slowly realized that, okay, we are working really good in healthcare. What next? So we thought that, okay, healthcare is not enough. We need to do something more. So we came up with a vision that every human being should live well, healthy, and happy for more than 100 years. So we brought out wellness and happiness into this. And what we found out was that in a life cycle of a patient, if you see, only healthcare is not enough. You need good nutrition as well. So we brought on nutrition where we have good diet plans for a lot of disease management systems, as well as people for weight loss and weight gain. And after that, while working closely in the nutrition department, we realized, okay, we need more. We need more in case of, we need more motivation. So that's where the happiness came in, right? So we thought, okay, how to use technology for happiness? So that's still we are working on, and we've brought, we are using meditation as well as motivation, as well as a lot of things in happiness, like activities for making people to stick to the plans and making easier for them to follow it. So our aim is to actually looking at a whole body. You need good healthcare, wellness, and happiness, all the three things together. And I think technology can play a really vital role in delivering all these things. So I'm really happy to come here. I think there's a lot of learning I'm going to take back from here. And I think I've already learned that there are a lot of standards. So we have gone through a lot of standards. I think we need a good platform where we can exchange data with other companies as well, because there are a lot of systems that are there in the country, and I think not a single company can cover the entire country as far as the healthcare systems are concerned. So I think there is a huge scope there, and probably it's a huge task, and it's going to be a challenging thing because everybody has their own mindset when they are creating the systems, and I think I'm looking forward for talking on these points as well. Thank you.
Good morning, all. It's a pleasure to be here. I'm Arun Patro. I work with IQVIA, which is the largest healthcare consulting firm in the world. At IQVIA, I head two verticals, health, finance, and nutrition. So we focus on delivering universal health coverage across the world and on running various nutrition-specific programs. My projects span Africa, Middle East, and South Asia. A couple of projects which are of national importance include Ayushman Bharat, where we run the largest PMU, which focuses on operations, so quality, capacity building, M&E, state coordination, the entire lot. We also work with the government of Egypt to roll out universal health insurance across the country. On the nutrition front, we work with 13 different states across India and ensure that, various goals which are set according to, the government and World Bank standards are being met. Prior to IQVIA, I was working with Niti Aayog, where I headed the technical support unit for National Nutrition Mission, Poshan Abhiyan. And before that, I was with the Chief Secretary of Chhattisgarh. So I was advising him on various matters. I moved into health tech consulting very recently. Most of my life has been spent in edutech and then in academic research. I was with Duke University as well. I was at the Fuqua School of Business. So it's a pleasure being here, and I think there's a lot to learn from all of you. Thank you.
Yeah, good morning all. I'm Dr. Neerav Trivedi. I'm a head and neck cancer surgeon working in Mehsana, which is about 1 hour away. And I also work as a medical director in Shanku's hospitals there. Thanks, sir, for inviting me here. I have practically studied my whole life in various diverse scenarios. So one of the things that fascinated me was how to optimize a cancer care in our country. And we all know, you are all senior people, and you know with the experience that one of the biggest challenge that we have is the diversity. If a patient goes to a good center, they get the best of the best care across the world, but many of the centers do not have proper resources or training and all that. So we have built a program that optimizes cancer care at any level or any setup in India. So if you look at the cancer life cycle of a patient, it starts from prevention, screening, and early detection, then appropriate care, then rehabilitative supportive care, and then end of life care and mental support all throughout. And if you think that all this can be done at a cancer hospital, it's not going to happen, because the oncologists are themselves so busy for time, and they just not even been able to give the proper expert care. So we divided the care into an expert care and a basic care like a primary cancer care, and we have designed a 4-tier cancer delivery system. We have a unique digital platform that allows this to do that. That starts with a district cancer control program where the health workers provide early detection and screening, and then they also provide aftercare, rehabilitation, and palliative care through this platform, which is like a self-help platform. So Intellect is this platform, and the health worker just follows the steps 1, 2, 3, 4. So there is a standardization of delivery. And then we have the same software allows oncologists to practice tumor board-based, protocol-based treatment and have them all this data exported into Excel format for research, data collaboration, and joint studies. We also work with various governments to help them aid their own district cancer control programs or help them set up a 4-tier cancer delivery system. Like Tier 3 is a standard cancer center, Tier 4 is a state-of-art, Tier 2 are district hospital cancer centers and all that. This software allows you to, the biggest problem in India is we don't have a standardized data. Either there is a hospital-based cancer registry or there is a community-based cancer registry. This software is designed in a way that you can actually have combination of these two and have a cancer patient tagged all the way up to a PHC. So you can have the entire data on your screen through this system. So I'm here mainly to learn from all of this and see how you can guide me, how I can take it to the next level. We have done this program is going on for last 3 years, and we have about 5 cancer hospitals supported, about 5,000 cancer patients, and three districts. So most of our model and the structure is properly tested, and we know we have overcome all the functional difficulties, and now in a phase where we want to grow across state and country and probably beyond. So I'll be happy if I can get the guidance and support to grow. Thank you.
So nice to have all of you here once again. Very warm welcome to IIM Ahmedabad, and I hope we will continue these discussions further offline, online, whenever we want to meet again. So time for tea. Okay, thank you so much, and we will begin our sessions just after 15 minutes.